Usually when we think about the architecture of the human body, we have this expectation of permanence.
Right, like it's a stone cathedral or something.
Exactly, like a cathedral. You look at the bones, the major organs, the structural supports, and you just sort of assume that once you reach adulthood, well, the building is finished.
Yeah, the blueprint is set, the walls are poured, and that's just that. It's deeply comforting to view our biology that way, honestly.
It is. We like to imagine we're standing on solid, unchanging ground. But then you step into the world of endocrinology and, like, tissue mechanics, and suddenly you realize you aren't looking at a stone cathedral at all.
Not even close. You're looking at a dynamic, highly demanding structure that requires a massive, continuous supply of a very specific fuel just to keep its walls from completely caving in.
Which brings us to the focus of today's deep dive. We are exploring a biological transformation that affects half the population, yet it is almost never discussed with the awe or, frankly, the detail it actually deserves.
It really isn't. And the scale of it is just staggering.
It's huge. We're talking about vulvovaginal atrophy, or VVA, which is now categorized under a broader umbrella called genitourinary syndrome of menopause, or GSM.
Right, GSM is the newer clinical term you'll see a lot more of in the literature now.
Yeah, and to really understand the sheer scale of this transformation, we've pulled together clinical trials, medical reviews, histological analyses, and anatomical texts, because we want to answer one incredibly specific question.
And it's a fascinating one.
What exactly happens to the natural folds of the vaginal wall? These structures, known as the rugae, as atrophy actually progresses. Okay, let's unpack
Well, I'm
this.
so ready for this.
Because whether you are directly experiencing this right now, whether you will eventually, or even if you just love understanding the hidden mechanics of human anatomy, this deep dive is going to reveal something wild.
It really is a complete architectural shift.
We are going to look at how a single hormonal shift triggers a massive physical and microbial collapse in the body, and how modern science is actually learning to reverse it.
But, to appreciate the severity of that collapse, we have to start with the original blueprint.
Right. What does it look like normally?
Exactly. Before we can look at the wreckage, we need to understand how this environment is built and why it looks the way it does in a healthy premenopausal state.
Let's lay down that architectural baseline then. When I picture a healthy premenopausal vaginal canal, I'm realizing from the sources it's not just a smooth, uniform tube.
No, not at all.
There are these very specific, intricate folds, the rugae. Why does the body expend so much energy building these ridges in the first place?
So the rugae are essentially transverse ridges or like pleats lining the vaginal wall. They are formed out of underlying supporting tissues that are covered by multiple overlapping layers of flat cells.
And those cells have a specific name, right?
Yeah, we call that the stratified squamous epithelium. And if you were to look at a cross-section of a healthy premenopausal vagina, the resting shape actually roughly resembles the letter H.
An H, like the walls cave in on themselves.
Exactly. The walls collapse inward, supported by a dense, spongy layer of connective tissue called the lamina propria, along with these main structural columns called the anterior and posterior columnae rugae.
So it's almost like looking down a hallway where the side walls are heavily pleated and constantly pushed toward the center.
That's a great way to visualize it.
If I think about it like an accordion or a heavily pleated skirt, those pleats allow the fabric to expand massively and then just snap right back into shape.
Right. They provide incredible resiliency and elasticity. Because of these folds, the tissue has a vastly increased surface area.
Which is needed for stretch, right?
Yes. That extra material allows for extreme stretch and extension during sexual stimulation and naturally during childbirth without tearing the underlying structures.
But the mechanical stretch is only half the story, isn't it?
Correct. That massive surface area is absolutely vital for the local ecosystem. The quote-unquote good bacteria in the vaginal microbiome need a sprawling, healthy landscape to thrive on.
Wait, so if these folds are so critical for basic mechanical function and housing the microbiome, how much maintenance does the body have to do to keep this accordion in working order?
What's fascinating here is that this architecture is entirely dependent on that continuous, high-maintenance fuel source we mentioned earlier.
Estrogen.
Estrogen. The body is constantly turning over those surface cells. It's a highly active construction site down there.
Constantly rebuilding.
Always. The tissues here are absolutely loaded with estrogen receptors, specifically ER, alpha, and beta. And when circulating estrogen binds to those receptors, it acts like a construction foreman.
Telling the workers what to do.
Exactly. It barks orders to the cells to actively grow, divide, and synthesize fresh, smooth muscle fibers, new collagen, and elastin. The integrity of those pleats relies completely on peak estrogen levels, telling the body to maintain the scaffolding.
But, I mean, construction sites need funding to pay the workers.
Yeah.
If estrogen is the funding, we have to look at what happens when the budget gets slashed.
And it does get slashed.
Because eventually the body hits the estrogen cliff.
It's a steep cliff, too. During the peri- and postmenopausal transition, the hormonal landscape shifts drastically.
How drastically are we talking?
Well, during a healthy premenopausal menstrual cycle, the ovaries act as these massive hormonal factories. They are pumping out estradiol at peak levels of around 800 picograms per milliliter.
800, okay.
But eventually, the ovaries deplete their supply of follicles. The factory simply runs out of raw materials and shuts down. After menopause, those estrogen levels plummet to below 30 picograms per milliliter.
Wow. From 800 down to 30. Imagine going from a roaring fire down to a single, sputtering ember. That is a staggering drop in a primary growth signal.
It's a profound systemic shock, honestly.
But is this strictly an aging process? What if the factory gets shut down prematurely?
It can absolutely happen prematurely. This state of low estrogen, or hypoestrogenism, can be iatrogenic.
Meaning medically induced.
Right. We see this frequently in patients undergoing cancer treatments like pelvic radiation or chemotherapy.
Oh, wow. Yeah, it happens in breast cancer survivors taking anti-estrogen medications like tamoxifen that intentionally block estrogen receptors. It occurs instantly if the ovaries are surgically removed.
That makes sense.
We even see a temporary version of it in postpartum women because the sudden loss of the placenta and the hormonal demands of lactation actually suppress estrogen production.
So regardless of how it happens, the factory shuts down. But here's where I want to push back a little on what we commonly hear.
Okay, go for it.
We hear a lot about the symptoms of sudden estrogen drops. The classic example is hot flashes. But women are often told that hot flashes eventually go away as the body gets used to the new normal.
Right, they usually taper off.
So why do the sources say the changes in the vaginal tissue remain chronic? Why do they actually get progressively worse over time? Like, why doesn't the vagina just, get used to the lower levels?
That is such an important distinction. Vasomotor symptoms like hot flashes are essentially a neurological reaction. The brain's hypothalamus is reacting to the sudden withdrawal of a hormone, and the brain can adapt.
Exactly. Eventually, the brain's thermostat recalibrates. It gets used to it. But the vaginal tissues are fundamentally different. They don't just sense estrogen. They physically metabolize it as a required raw material.
Ah, so they needed to physically build the tissue.
Right. They needed to synthesize those structural proteins we talked about. Without the foreman, the construction literally stops.
So the workers just go home.
Basically. Without the estrogen signal, the tissue undergoes continuous involutional changes. The cells aren't receiving the command to rebuild collagen or maintain the localized blood supply.
So they just wither.
Yeah, the tissues slowly starve. And unlike a hot flash, cellular starvation doesn't just go away with time. It progresses. The tissue physically shrinks and degrades.
And that starvation brings us to the core focus of today's deep dive. The physical fate of those vital vaginal folds. Because as that underlying collagen degrades, the entire landscape of the vagina fundamentally changes.
It is a dramatic anatomical shift.
We're talking about a total disappearing act.
Yeah, the vagina literally loses its rugae. As the collagen and elastin break down within the lamina propria, that structural scaffolding we talked about completely collapses.
The pleats and the accordion just vanish.
Completely flatten out. The accordion can't expand anymore.
Here's where it gets really interesting, because the visual change is striking based on these anatomical texts. If we think about our earlier analogy, it's like taking a lush, rolling, three-dimensional landscape and essentially just paving it over into a flat, dry, brittle parking lot.
That's entirely accurate. The epithelial surfaces become flattened. The tissue loses its papillae.
One or papillae, exactly.
They're these microscopic, finger-like projections that normally push up from the deeper layers to deliver blood and nutrients to the surface.
Oh, so the nutrient supply lines get cut off.
Right. And without those supply lines, the vaginal canal itself physically narrows and shortens. We also see features of keratinization, where the surface becomes somewhat hardened and tough, trying to protect itself.
But poorly, I imagine.
Very poorly.
That structural collapse must completely change how the tissue looks to the naked eye.
It does. A healthy estrogenized mucosa is typically plump and pink because it's thick and very well vascularized.
Lots of blood flow.
Right. As atrophy sets in, it initially turns red and inflamed because the tissue is thinning out, exposing the underlying blood vessels.
I know.
Well, eventually, as those blood vessels retreat and die off from lack of use, the tissue develops a pale, shiny, and severely dry appearance.
So the physical consequence of losing these folds is a total loss of elasticity. But it's also a dramatic loss of thickness, right?
Oh, absolutely.
Because instead of producing multiple overlapping layers of protective cells, the tissue stops producing its top layers entirely. It leaves behind only a thin, single layer of parabasal and basal cells lining the wall.
Right, and because the tissue is now flat, paper-thin, and dehydrated, it becomes incredibly friable.
Friable meaning fragile.
Extremely fragile and easily torn. Minimal trauma can cause serious damage. We are talking about normal sexual activity or even just a routine gynecological exam causing tearing.
Petechiae?
What are petechiae? Tiny bleeding spots under the surface. It causes painful fissures and, frankly, severe pain. The medical term for that frank pain during intercourse is dyspareunia.
So without the folds to absorb the friction, and without the thick layers of surface cells to act as a cushion, the deeper connective tissues and nerve endings are suddenly just, well, exposed.
Completely exposed.
How does the body cope with this mechanical vulnerability?
If we connect this to the bigger picture, the body copes very poorly. That extreme thinning makes the deeper tissues highly vulnerable to chronic inflammation, ulcerations, and sometimes even the physical fusion of the labia.
That sounds awful.
It is. The loss of the rugae isn't just a loss of stretch. It is the destruction of the body's primary mechanical protective barrier.
But the breakdown doesn't stop at the mechanical level. And this is the part of the sources that truly blew my mind.
Oh, the microscopic stuff.
Yeah. If the physical folds are gone, that massive surface area we talked about is gone. How does that physical flattening trigger a chemical and microbial domino effect?
It's a perfect example of how anatomical structure dictates physiological function. So, in a healthy state, as those thick superficial cells naturally reach the end of their life cycle, they die and shed off into the vaginal canal.
Right.
And when they break open, they release a massive payload of glycogen, which is a complex sugar.
Okay, so the shedding cells are essentially dropping sugar into the environment.
Yes. And that glycogen is the sole food source for lactobacilli.
The good bacteria.
Exactly. They are the commensal bacteria that serve as the defending army of the vaginal ecosystem. So when the rugae flatten and the tissue becomes too thin to produce those thick superficial cells, the glycogen supply just halts.
The food source vanishes?
Yep. Without glycogen, the lactobacilli literally starve to death.
Well, why do we rely so heavily on lactobacilli for defense? Like, what do they actually do?
Well, the lactobacilli consume that glycogen and metabolize it into lactic acid.
Ah, acid.
Right, that constant production of acid is what keeps the normal vaginal pH very low, typically less than 4.5. It creates a highly acidic bath that acts as a primary chemical defense mechanism against invaders.
So the physical loss of the folds actually changes the chemical pH. That's incredible. It's like losing the trees in a forest actually changes the chemical composition of the soil.
That's a brilliant way to put it. The physical structure, the rugae, provides the surface area for the ecosystem, the lactobacilli, which then maintains the chemical defense.
The acidity.
Right. So when the folds disappear, the entire defense system just collapses.
Wow.
When the lactobacilli die off, the lactic acid production completely stops. As a result, the vaginal pH shifts dramatically, rising from a healthy hostile 4.5 up to an alkaline level, somewhere between 6.0 and 8.0.
And I imagine an alkaline, flat environment is just bad news for the host.
It's terrible news. It becomes a prime breeding ground for pathogenic bacteria that normally couldn't survive that acid bath.
What kind of pathogens?
We see massive overgrowths of streptococci, staphylococci, and coliform bacteria moving in from the gastrointestinal tract.
Oh, geez.
Yeah, this bacterial shift leads to recurrent urinary tract infections, UTI's abnormal discharge, and the noticeable odors that are hallmark symptoms of GSM.
It's just a cascading failure.
Exactly. Structural, chemical, and microbial, all starting from a single missing hormone.
Okay, we've mapped out the architectural collapse. The building has been condemned, the foreman has left, the security guards have starved, and the invaders have moved in.
Pretty bleak picture.
Seriously. So the real question is, how do we rebuild it? If the rugae have completely flattened out into this pale, fragile parking lot, can they ever come back?
The good news is yes. Modern science has developed several interventions, and they approach the rebuilding process from fundamentally different angles.
Okay, let's start with the most obvious one. If the root problem is this dry, fragile tissue, my first instinct is just to moisturize it. Can we simply hydrate the tissue to fix the problem? We see hyaluronic acid used a lot for this in the clinical reviews.
Hyaluronic acid is a natural polysaccharide, and it acts as a humectant.
Meaning it traps water.
Exactly. It has this incredible molecular ability to draw and trap water molecules at the surface of the tissue.
Okay, so that sounds helpful.
It is. It provides wonderful, non-hormonal temporary relief for vaginal dryness by increasing moisture and reducing friction.
Why?
But it doesn't command the body to build new epithelial layers or regenerate collagen deep in the scaffolding. It hydrates the existing flat tissue, but it doesn't fix the underlying architectural loss.
It's a Band-Aid. So we need the construction foreman back on site. Which brings us to estrogen therapy, either taken systemically or applied locally as a vaginal cream or ring.
Right. This is directly replacing the missing fuel. When you apply estrogen to the local tissue, the remaining receptors grab hold of it, and the body literally resumes construction.
It just wakes back up.
The cellular machinery wakes up, it restores the epithelial thickness, which brings back the glycogen production, feeds the lactobacilli, lowers the pH, and improves the local blood flow.
It reverses the whole domino effect.
Completely.
But what if someone can't take estrogen? Like the breast cancer survivors we mentioned earlier, who need to keep their systemic estrogen levels as close to zero as possible. Is there an alternative that doesn't flood the whole body with hormones?
There is a really fascinating alternative using vaginal DHEA, which is also known as prasterone.
Prasterone, okay.
This relies on a highly specialized concept called intracrinology. DHEA is a raw precursor steroid hormone.
Meaning it turns into other hormones.
Exactly. And when you apply it vaginally, it doesn't circulate through the bloodstream to be processed by the liver.
Where does it go?
The local vaginal cells absorb the DHEA directly and use their own internal enzymes to convert it into both estrogen and androgens, like testosterone, strictly inside the cell wall.
Wait, testosterone? In the vaginal tissue?
Yeah. Androgens are incredibly important for female sexual health and tissue integrity. They help rebuild connective tissue elasticity and improve nerve signaling.
That is fascinating.
And the beauty of vaginal DHEA is that this conversion is completely localized. It rebuilds the architecture and the rugae from the inside out. But because the hormones are made and used entirely within those specific cells, it doesn't significantly raise hormone levels in the rest of the body.
That is incredibly targeted. Okay, so hormones make sense. You replace the chemical signal. But there's another intervention we're looking at in these trials that seems completely counterintuitive.
You're talking about the lasers.
Firing a fractional CO2 laser into the tissue? How does burning a fragile, paper-thin tissue actually help rebuild it?
I know it sounds paradoxical, but the mechanism relies on the body's deeply ingrained survival instincts.
Okay, walk me through it.
The laser emits a beam of light that is broken up into tiny dots. It creates a grid pattern of microscopic ablative microwounds in the flat atrophic tissue.
So it's intentionally damaging the tissue?
Yes, it intentionally causes controlled thermal damage.
Why would we ever want to damage tissue that is already literally falling apart?
Because the body perceives that thermal damage as an acute catastrophic injury, and that forces it to initiate a highly coordinated, aggressive wound healing response.
It shocks the system.
It wakes the tissue up violently. The thermal damage triggers 3 rapid phases. First is chemotaxis, where the body sounds the alarm and rushes immune cells and growth factors to the area.
Okay, phase 1 is the alarm.
Right. Second is phagocytosis, where cells act like a demolition crew, cleaning up the dead, atrophic tissue, and all the debris.
Clearing the site.
And then the most important phase is neocollagenesis.
Building brand new collagen.
Exactly. The laser forces the fibroblasts, which are the cells responsible for building structural framework, to go into absolute overdrive. They lay down a fresh, dense network of extracellular matrix, new collagen, and new blood vessels to heal those microscopic burns.
That's brilliant.
And when we look at the histological exams, the tissue biopsies, after this process, we see that the body didn't just heal the wounds, it actually restored the 3D papillae, increased the glycogen, and physically rebuilt the rugae.
So what does this all mean? If I can summarize this, hyaluronic acid is like watering a very dry lawn. Estrogen is like replanting the grass with fresh seeds. But the CO2 laser is like aggressively aerating the soil, poking holes in it to force the roots to panic and grow back deeper and stronger.
That's a spot-on analogy.
Are we literally tricking the body into rebuilding the rugae?
This raises an important question about how we view aging tissues as a whole. Because what the laser intervention proves is that even severely atrophic, flattened tissue hasn't lost its inherent ability to form rugae.
The blueprint is still there.
The genetic blueprint for the cathedral is still there. The workers are just asleep. The tissue simply lost the chemical signals, the hormones, or needed a biological imperative like wound healing to start building again.
That is profoundly hopeful. It means the structure isn't permanently gone. It's just dormant, waiting for the right signal to wake the system back up.
Exactly. The architecture can be saved.
So to wrap up this deep dive for you, we've seen how a plunge in estrogen acts as a demolition order for the vaginal rugae. It takes a dynamic, elastic, highly folded environment and slowly starves it.
Flattening it into a thin, fragile tube.
Right, and that mechanical loss triggers a massive cascade of chemical shifts, starving the good bacteria and completely altering the body's natural defenses against pathogens.
The whole ecosystem crashes.
But we've also seen how targeted science, from replacing local hormones and engaging endocrinology to utilizing fractional lasers, can actually coax that complex architecture back into existence.
And before we go, I want to leave you with one final, very intriguing piece of the puzzle pulled from the historical data in our sources.
Oh, I know what you're going to say. This is so interesting.
Scientists tracking these structural changes found that objective signs of vaginal atrophy, including the physical flattening of the rugae, were actually less evident in postmenopausal women who had higher natural androgen levels and who remained sexually active.
Wait, does the data define sexually active in this context? Because that's pretty broad.
It does. The studies specifically noted women having intercourse 3 or more times monthly compared to those having it less than 10 times yearly.
Wow. So it really leaves you to mull over the classic use it or lose it theory.
It really does.
Does the physical mechanical stimulation of the tissue, combined with those local androgens, actually help preserve the structural integrity of the rugae even when the primary estrogen fades away?
It suggests that the body's mechanical and chemical systems aren't just passive receptors of hormones, they are in a constant dynamic dialogue with our behavior and our physical environment.
That is wild. What a place to leave it. Thank you for joining us on this deep dive into the fascinating microscopic mechanics of the human body. As always, keep questioning the science behind how we function, and we'll catch you on the next one.